Hello everybody, my name is Peter Hunt and I come from Philadelphia in Pennsylvania. The patient we're going to be working on today is Kathy. She's been a patient in my office for a long time and she's always had some problems. She lost her maxillary teeth in her early 40s because of decay and she's been wearing a full denture ever since. She'd love to have a fixed implant-based dentition. This is the view of the denture in the mouth. As you can see, the appearance overall is satisfactory, but not certainly good. Here's the more dramatic view, which is with the denture out. And you can see that she has a pretty good ridge and a pretty good amount of attached gingiva over the crest of the ridge. But for years I felt intimidated from treating this case because of several things. First, it's difficult to get a fixed reconstruction with the precision that you really need to be able to get the aesthetic result that you're looking for. So aesthetic demands are also important. This lady wants to have a very good look. There are also financial considerations. This is not something to be undertaken lightly. And there are time constraints because she comes from quite a distance away. She has to drive about 100 miles to get to see me. So here's the situation as it is in the beginning, with the full denture, with the edentulous arch. But recently I realized that I had technology which allows me to move past all of these obstacles. And these are a Galileo's 3D scan, the CyCat surgical guide technology, Camlog guide technology, and Camlog implants. We'll see Camlog custom abutment technology in place. And we'll see how 3Shapes technology for CAD/CAM processing of emergence profiles is also an integral part of this whole scenario for the case. It starts with a wax up. These days I might even be able to avoid this stage of the game. But it starts with a wax up of what would be proposed. And the important thing about this is that there's really no room for a bar or a frame or even any form of gum work. That means that the reconstruction has to be a crown and bridge implant supported reconstruction. It's very important to be able to do this assessment. Many people quote for a case based on the idea that it will be an all-on-4 or all-on-6 with a flange and really a modified denture. But in this case, there's just not the room for the flange work. And it throws a lot of strain onto the demands for the case. The next question is about the number of implant supports. This is controversial. Some people try and get away with very few, perhaps 4 in a case like this. Some people go for 6. I'd like to see 8. We'd like to have 2 in the molar regions and 2 in the canine regions. We could probably manage with that as a minimum. But I believe that adding 2 more in the premolar regions and 2 more in the central incisor regions adds a great deal to the case. Because then we have the ability to split the reconstruction into 4 3-unit bridges. And this makes the technical work simpler and easier, and the maintenance much more easily managed. So this would give us a simple, easily maintained restorative plan. Here we are now where this wax up has been reproduced as a radiographic stent or guide. And this is really where it's mixed with radiopaque resin. And this is why the teeth are looking so white. The anterior flange is left off of this in order to ascertain the precise location for emergence of the teeth. I want to see where they're going to be able to touch the ridge. And I'm also checking very carefully to make sure we have the right center line and the right appearance that we might consider making for this case. And here she is with this in place, we get some idea of the smile appearance that can be generated with this type of arrangement. She's always wanted white teeth. Now she's got white teeth. But now comes the interesting part, making them fixed and solid and part of her. The scan stent is attached to a special bite plate, which is supplied by SciCat, prior to taking the Galileo's 3D scan. This enables the relationships to be reproduced essentially on the computer scan system. Now, I also want you to notice in the lateral incisor regions and also in the second molar regions, we have placed mini implants. And this provides complete stability for the stent. I'll show you them in a moment. So here we see the stent in place, the radiographic guide or stent in place. And now we see the mini implants. And the mini implants were placed shortly before this procedure. And the stent was made to go right over them and to be fixed and very solid on them. This is critical because if you're not careful, any surgical guide can slide around in an edentulous arch to a remarkable degree. The soft tissues are very thick and mobile, and you can make a lot of difference by placing the pressure on the surgical guide at the wrong place. Simply screwing it into place does not necessarily solve the problem because you might have screwed it into the wrong place. By placing 4 mini implants like this and using this relationship all the way through, then it's possible to use this in the radiographic guide and in the surgical guide. I feel this is a very critical factor. And in fact, I would not consider doing a full arch case like this one without using this process. So here we see the arch with the mini implants, and the guide is now in place. Here she's getting the 3D scan. It's important to keep everything stable while it's being done. So here's the scan up on the screen, and we're going to start looking around at each one of these 8 implants that we're going to be placing. Here's the first one in the maxillary left molar region, as far back as we can go. And you can see that with a 4.3 by 9 millimeter implant, we can find plenty of room to put it in the bone. Coming further forwards to the premolar, you can see that this is a little bit more difficult because the bone volume is reduced, but we can get in a 4.3 by 13 millimeter implant here. So that should give us good stability. As we come to the canine, again a little narrow, but we're going to place again a 4.3 by 13 millimeter implant. And for the central incisor, and in fact all of these anterior ones are going to be 4.3 by 13, but we're actually going to put them into a 3.8 by 13 millimeter one. A slightly smaller diameter channel is being cut, then the implant is being placed. So we should be fine with all of these in this region. As we come to the posterior, though, we have a little bit of an issue, because where we want to place the implant is where the sinus is also. So we can get bone volume by taking the implant a little more distal, but that impinges on the mini implant that we have in place. So we're going to have to compensate for that, and I'll have to show you that in the guided scan system that we have to be able to develop the channel in the first place. So it does look as though we can place 8 implants in the maxilla of this patient in bone, and that's basically the procedure that we're going to be doing all in one, providing we have the surgical guide to place these in the exact position that we're looking for. Now here we've converted the radiographic guide into a surgical guide. This has been done by SciCat in their facilities in Germany. They do a beautiful job. And it's just taken the radiographic guide that we had, and it has created this model and adjusted the model a little bit. You can see in this next shot that this will sit nicely over the top of the model, and I can use this in the laboratory to generate the channels in the model. So here are the channels in the model, and they are okay to receive the analogs. And here is the positioning of the analog implants in the model. And because of that, we're able to establish the emergence profiles that we would predict and want to see developing in this case. And we'll show you this technology a little bit further down the line. We're able to produce a zirconia emergence abutment. And we're also able to produce a provisional restoration, which will be placed at the time of surgery. So there's a lot of upfront work on a case like this, but it makes for the whole procedure to go much more smoothly than you could ever imagine. And we'll show you that. Now we have to have a look at the Camlog guide components. Camlog guide is the precision placement technology used by Camlog to make sure that the implants are drilled in the channels, and also then the implants are placed in the channels. As with many guide technologies, it's all based upon a guide sleeve. This is the component which is stabilized in the plastic surgical guide. And first it starts with a gingival punch. Then there's a variety of different drills. These form drills are using a cannon drill, which is a one-bladed drill. So these, if used freehand, will go all over the place. They have to be used in the guide. You should never use them freehand. The other thing that's different about them from most conventional drills is that they go with increasing length, not increasing width. So you start with the 3/8 by 6, then you go to the 9mm length, to the 11mm length, and to the 13 if necessary. Then there's also an expansion drill if needed, but in this case that will not be the case. The guide technology is also taken forwards and used into the carrying system which carries the implant. There's a special insertion post which controls the positioning of the implant down through the guide sleeve. Let's see them in action. First of all, here's the insertion driver and then the torque wrench. So let's just look at the action of three components. First, the gingival punch. And you can see how this can slide and is guided in its pathway by the surgical sleeve. Then let's look at the drill. We'll use just one drill here, but you can see again how that portion slides within the sleeve, and this is what controls the accuracy and the precision of the channel. There's also another very important factor. There's a depth stop here, and the depth stop will control the depth of placement of the device. And finally, we can see the idea about the placement of the implant, because again, this special sleeve engages this carrier and the carrier takes it down to place until the depth stop ensures precise vertical positioning. So here we are now in my clinic in Philadelphia, and this is Kathy. She's looking a little bit nervous about it all because this is where we're going to start removing this denture and getting into the implant placement. Here you see the surgical guide. It's being located over the 4 mini implants, and this portion starts with the gingival punch. And you can see it's very quick and fast. Now, some people believe that you don't really need to use this technique, that you would be better off using a flat procedure. And you can certainly combine a flat procedure with a guide procedure. Don't make any mistake about that. The simple question is whether you have enough gingiva in the region. And in this case we do, so we can do the gingival punch procedure. The most difficult part of the gingival punch procedure, as far as I'm concerned, is getting the plugs out after they have been punched and removing them. They're attached to the base, and it sometimes can be a little bit difficult. Now, I'll tell you that some parts of this video are speeded up, so I'm making it look a little bit easier than you might think. And again, you can see a good zone of attached gingiva here. That's critical. You must have a good zone of attached gingiva around your implants as far as I'm concerned. Now we're going to the 3/8 by 6 millimeter spade drill. This is cutting through the cortical plate, and it rattles and rocks around quite a bit until it gets started and the guide sleeve takes it over. And I'm concentrating in the first place on doing 2 implants. These are the 2 premolars. Now we're going to the longer one, and it starts to pick up speed. It really goes along very smoothly and fast. And I'm holding this up tight against those mini implant pins while I'm doing this drilling procedure. Now we're at the 11 millimeter drill. And this is the final 3/8 by 13 millimeter spade drill. Now here goes the implant into the site. Screw down by hand. Now it's engaged with the ratchet, and this is taken down until it reaches the stop region. And we also will just take it so that we have a line to the buckle, because that gives us the indication that we're looking for the cam and the restorative processes. Now the advantage of this is once you've got these 2 in place, everything becomes remarkably stable. So it's really securing this to the 4 mini implants. That's why there's no need for any additional transosseous stabilization. And I can get a hold of it, and you can see this is now very stable. Now the drilling sequence is repeated for the anterior sites, and again, as before, 3/8 millimeter diameter drills are being used. 4 3 millimeter diameter implants will be placed into these channels, so this reduces the potential for perforations and gains increasing stability. So let's pick it up now with the larger drill, the deeper drill. Just take your time, be patient with it. Let the drill do the work. You've done the work before in the setup. You have remarkably little control over this in many respects. It's a bit daunting when you first do guided surgery. But if you've done your preparation right, it's going to go fine. Here goes in one of the implants for the canine. Again, you can be very precise with the positioning of these. We go from one side to the other just to make sure that the balance is not being upset. And you can go really quite fast with this whole process. The putting in of the 8 implants in this case took us 45 minutes from start to finish. So now we've got 6 implants in. Just tightening this up finally. We're getting very good security here. It's getting quite firm. Good. Now we're going to repeat this in the distal region. The 2 here are a little bit different. These are shorter implants. This is on the one side where we can accommodate the same technology as we've seen before. So we'll do that one first. Here goes the implant. Wasn't much to see there, was it? Sorry about that. But it's straightforward. Once you've seen one, you've seen them all here. This is very soft bone. On the other side, that was where the post was going to interfere with the implant positioning. So here we're doing this through a 2 millimeter guide channel, and with the 19 millimeter drill we can generate a 9 millimeter channel down below the depth of where we want to be. And now we're at the stage where we're removing each of the devices by unscrewing each insertion tool. You cannot take it out without removing each one individually. You could never get the implants perfectly parallel. And you can see even removing one of them can be sometimes a little bit tough just to start with, but it's possible. Just takes a little bit of time, little squeezing. Some of them are a bit more difficult than the others. Here's the premolar one, and here's the molar one coming out now. Now, on the other side, we have the access pilot channel drill. We're going to do this now freehand. Straight through the gingival, enlarging this out to the depth that we need. So there's quite a thickness of gingiva here. So we're using the 3/8 drills now, and we're taking this down to the right depth so that the implant is buried completely in the bone.
Notice that the mini implant has now been removed.
It's soft, so we hold the device before we're removing it. And here we go. Now comes the insertion of the custom zirconia bases.
This can be quite a squeeze. It takes a little bit of time to expand the soft tissue.
Now we're immediately post-surgical. You see the posts in place, and you see the zirconia coming through the gingiva. The margin in general is supragingival. That's what we intend to establish. In some cases, for example on the one canine, it's not as supragingival as I would have liked. And then we place the provisionals. This is how the patient is going to go for 3 to 4 months. We cement this with something fairly firm. We want to make sure that this is going to be as solid as possible. Often if we feel that the patient has a very tough bite, we'll make a metal frame within the provisionals. And let's listen to her. Could these feel pretty good at the moment?
They feel wonderful. It's really great not to feel my plate. The roof of my mouth feels good.
And you feel more comfortable about smiling now?
I'm beginning to.
Yeah? And
I haven't smiled in years. I
Really?
cover my teeth when I...
And people sort of notice that you're looking a little...
Everyone has noticed. Some people have noticed a difference in the shape of my mouth in here.
Uh-huh.
And everybody wants to see them. I have to open my mouth so they can all see them. They think they're beautiful.
Yeah. But this is only 10 days after the procedure.
It's only 10 days.
Yeah.
I worked after the procedure. I went home, and then the following day I went to work, and I worked 12 hours, and I worked the next day, and I just kept working and take my mind off all the thumping, and it never had any real serious pain.
You never had any really serious pain? Really?
Just little bits of thumping here and there, but I would keep working and keep my mind off it.
What do you mean about thumping? About when I was beating you up in the middle of the procedure or afterwards?
No, like little thumping in your gums. Like.
Okay. All right. And everything feels very stable. You can eat better now, no trouble at all.
I started eating soft things, and then I tried all the things you said I couldn't, like beef and chicken. Just little bits.
Fantastic. Thank you very much, Kathy.
I love them.
So now we move to 3 months later. When she comes back in, we are evaluating the whole situation. And you can see that things are healing up. Things are looking good. The provisional's been stable for this period of time. And at this time also, the implants are very stable. It's been left undisturbed for this 3 months. And this is when I started realizing that this could be a really great case, but to make it that much more special, we would need to modernize the lower arch as well. Now in the lower arch, she's wearing a partial denture. She has a few teeth left. She has one implant already in place, and it's been used to help stabilize the denture. And in this case, we now have questions again about the implant placement. And it's fairly straightforward. We'd like to have 2 in the molar region, 2 in the premolar region. The canines are okay, so we'd like 2 in the lateral incisor region. This means, again, you can have small unit crown and bridge work. 2 3-unit bridges in the posterior region, 1 4-unit bridge in the anterior region, and 2 separate crowns. It allows for a restorative plan with small bridge units. So let's do it. Okay? Again, we make a full arch lower provisional restoration. We've taken out the teeth and we have placed the implants as needed around the whole arch. The bone was very stable here, so they could do immediate loading. So this is the immediate lower arch case with the immediate full arch provisional. Cross arch stabilization to be able to keep everything under control as much as possible. And now let's talk about developing the final case, because this is very important. We need to be able to transfer this provisional arrangement to something much more permanent and much more aesthetic. But the aesthetics that we've got for this patient are actually quite good at the present time. She's functioning well with it. So to a large extent, we want to copy this whole arrangement. Now let's just think. First of all, we have a superstructure, the existing provisional reconstruction, which can guide us to the form and the dynamics of the reconstruction we want to place. We have also an infrastructure, which are the preparations and the gingival emergencies of the posts that we have placed. And we also have the implant positions, which can be considered the substructure. Most people start from this and work their way up, and sometimes I think that that's a bit unfortunate. You're avoiding all the information that you've picked up from the cases you've done it. And so just have a look and see how we can do this. First of all, we're going to start by picking up the existing abutments in an overimpression. And we do that by using the provisional reconstruction as the impression device. And we take an impression over the top of the provisional. We pick up the provisional and then we pick up the existing abutments. We're going to add analogs. We're going to pour a new master model which will copy the existing emergence profiles. So we see the emergence profiles that have been developed in this case. And we can modify them a little bit for the final case. The third is to take a thermoform of the existing provisionals, and then we can apply this over the master model. So we know where we want the dentition. And between the dentition and the implants, we can develop the preparations and the emergencies of the devices that we want. So then we can refine the emergence profiles, define the gingival margins, and form the final custom abutments. And this, I'm going to show you a Camtasia of the CAD system that we use, which is from 3Shape. Here we have the posts in place, and these are provisional proposals. They're not going to be what we use finally. We're going to modify them. We're going to concentrate on this one picture that we have here for the central incisor. And you can see that we have the ability to reshape everything. We're trying to make it look as though a central incisor is emerging out of the soft tissue. Now he's bringing the margin down into the right position. And here you see the post being placed in the right position. The gingival emergence has been done, and now it's a matter of getting the post formed correctly. Now the difficulty here is that you don't see the overlay or the thermoform of the reconstruction in place. Now it is. So now the preparation portion can be changed and angled and oriented correctly. So here we are now with the final posts in the model ready to be taken to the mouth. And we have the thermoform which can go over them, and this can allow us to get the shape that we want for the final reconstruction. So let's take them to the mouth. let's just have a look at these two central incisors. You can see that the right one, does not fully fill out the sulcus. And that's been done in order to help change the center line. And you can also see the contours of this. You'll never get these sort of contours in a pre-made component in titanium or whatever it may be. This is only possible in a custom-made device. And here we see the clinical situation with the papilla being reshaped and just moved a little bit in order to change the center line. We're enhancing the papillae. It's always useful to have more papillae, avoid the black triangles. We're improving the aesthetics, and we're minimizing cement retention because these margins are just at the gingival margin, and that means we're not going to be pushing a whole lot of cement down subgingivally. You shouldn't push any cement down subgingivally. And here's the component of this, which is a detachable custom zirconia component, which goes up onto this CAD-CAM Titan CAD-CAM base. So you get the best of both worlds. You get the metallic component down inside the implant, so there's not going to be any abrasion of the inside of the implant. You have the ability to be able to change the core if you want to, for whatever reason, and the cement retains the two components together. So let's see how it's done. This comes over and it fits down over here, and you have at this stage a resin composite luting cement. This comes down, there's a little collar which develops at the gingival. This gets taken away and it gets cured. You can't use a totally light curing system for this. You have to use an all-in-one cure, or auto cure, or light and dual cure, whatever it may be. You have to be able to make sure that it's going to cure, because you will not get any light passing through the zirconia core. For that reason, we put these components on a little heating block. It's a little coffee pot warmer, so that you increase the rate of conversion of the plastic down underneath. And we've never had one of these fail or come separated away. So it's very reliable.
We're now ready to take the case forwards.
We're now trying in the zirconia posts, and we need to be prepared to modify them. We call this an abutment try-in visit. And in this, we're going to be looking at the subgingival contours. First of all, we can adjust these if necessary. If the papillae is a little strong, such as down in the left canine region, then we can recontour the subgingival portion of this emergence. And in the maxillary anterior region, we're playing with the aesthetics based on that same reason. We can adjust the margin contour. So, for example, this premolar, the margin is higher than we would like. So we can easily take that down and make it gingival or subgingival. It's easy enough to be able to do that. We might want to change the preparation form. This maxillary left canine looks a little prominent in its buccal contours. So those can be taken in, and we can get a better contour here. And we may need to modify the occlusion. For example, this abutment here looks as though it's too long. So it may be difficult to fit in all of the ceramic which needs to come over the top of this. So this can be taken up fairly simply and fairly easily. And this is something that the clinician can control. He can look at this as a set of preparations that you would have in a full mouth reconstruction. Once these have been adjusted, and if you're comfortable with them, then you can also at the same time do what we call a plastic try-in. And this is where the full final reconstruction is tested out for contours and occlusion and a whole number of other things. Such as you can see here, we made a slight centerline adjustment. We took it over a little bit. We also added to the incisal edges, not only of the central incisor, but also of these three teeth here, and that is what we checked primarily with the smile view. And We can do a buccal contour modification on this canine here. The preparation was taken in. Now the tooth can be taken in a little bit as well. You can see it's not as aesthetic as the canine on the other side. We can also pick up the ridge. If there are pontics to be touching the ridge, we can add a little material to there and just pick those up, and that will easily enable us to be able to contour the final case correctly. So there's a lot of things which one can do which will make this case come together. This is the time where the dentist has control over the reconstruction, and it's for him to make the aesthetics that he wants to see in the final case. Because essentially, the final case is just going to be copying the details which are given by this plastic try-in. Let's listen to see how she is. And you feel perfectly normal?
I feel perfectly normal.
Yeah?
It's amazing when I look in the mirror, it looks perfectly normal. It looked like they did when I had my own teeth.
So we're on the right track for you?
We're on the right track. We're not quite there yet.
No, next week. Okay.
Yes, I'm ready.
Okay.
I want to get home with them now.
Yeah. And it's when you can see the smile of a patient and they can try it in that you start getting the confidence of being able to produce the final result and also of being able to satisfy the patient. So let's have a little summary. Here we were with the original denture, which is actually more correctly a situation like this, which is edentulous. We then placed implants and the temporary reconstruction. This was the immediate maxilla. This then moved to where this was in good shape, taking nicely, and it's where we decided that we needed to do something with the mandibular arch. So stage 2 was going to the immediate mandible. We placed the implants, did a temporary reconstruction. This was immediate load. The third time was when we did the abutment try-in and the plastic try-in. That's a combined visit. We can adjust the abutments, we can change and modify the plastic try-in. And this leads us to the fourth major visit, which is where we have the final case. And this can go in predictably with minor adjustments and where the patient can see straight away that you were able to produce the result that they were looking for. Here again, the original, the posts in positions with the implants below, and then the final reconstruction in 4 small 3-unit bridges, which will be easy to maintain and look after. From here through to here. Progressive, controlled, where you are in command and where you can produce the results that you want to produce and the patient is desiring when they walk in the door in the first place. Again, radiographically, the original. Now we've moved to the final case. Everything's stable, everything's solid, everything's reliable, and it should be able to be maintained well over a long period of time.
Feeling wonderful. Teeth are doing fantastic. Still having adjustment, getting used to them. All these things in my mouth. Playing with them. I'm able to eat just about everything. No pain.
You've never had any pain particularly? Or
I have
just
never
now?
had any pain through this whole thing. The little thumping in the beginning, like little heartbeats. But after that, no pain.
That's fantastic.
And I think about it quite a bit and wonder why. But I would recommend this process to anybody, certainly over dentures.
Well, what's it like to be clear of the denture now?
I can't even explain it. There's no plastic in my mouth. I'm able to talk better. Things taste better. I feel, in general, I feel better about myself. I'm not worrying about them moving around. I'm not worrying about food being stuck in them. All those little things. So I feel better about myself.
That's good.
And everyone has noticed it. I shared this experience with everyone I worked with. So along the way, everybody wanted to see the work and the final picture. Everybody's looking in my mouth and amazed. No one knew that I didn't have my own teeth until we started this. It's been wonderful.
They all like the way you look now?
They love it. They love it.
That's fantastic.
Beautiful teeth.
Yeah?
The cheesy smile.
Okay. Thank you so much, Kathy. Take care.
You're welcome.
Bye.
Bye.
Conclusions. Modern technology can dramatically cut the time and the number of visits for a complex implant case while greatly improving the precision of the final product. While the costs of the technology and supplies for a case like this may seem high, the efficiency and predictability of the procedures allows for great savings. In most situations, the dental laboratory has to guess at factors which are critical, such as the smile aesthetics, the vertical dimension of occlusion, the jaw relationship. The great advantage of the process shown here is that it allows the clinician full control over all these variables and the stages of the case. You're not losing control, you are gaining control. The technology applied must always respect the biology of the region. That's why you have to adjust contours. That's why you must make sure you don't place cement down underneath the abutment. 6. It's amazing what we can achieve. I would not have been able to achieve this so easily and predictably in any other way. So in that respect, it's fantastic. So I'd just like to say thank you to those who've helped with the making of this program. Geordie Ballard and the Camlog crew for helping with equipment. John Smithson from Sirona with the CAT scan technology. Gerhard Zuendorf from SciCat for the surgical guide. Boris Baranov from my office, Ella from my office, wonderful assistant, Brian Secchi for videography, Broadway Dental Laboratory for doing the milling, and Andrew Lovett, my partner at Red Moon and at Camlog Connect. Thank you for watching.